Lovely to have you all join us. So we're going to talk about MatX, or improving maternity experience. And don't panic about the fact the date on our presentation is 2 days ago. The reason for that is that we also gave a talk to a whole crowd of obstetricians, labour ward leads, on Sunday. And we thought that part of the point of MatX is that we treat everybody equally. Everybody's viewpoint is important, and we are doing exactly the same presentation in terms of midwifery now for the RCM as we gave to the obstetricians on Sunday.
So that was Florence.
Oh yes, sorry. Good point. I'm Florence.
And I'm Gill, and I'm the creator of Who's Shoes, and we love doing this work together, and we hope that as many of you who already know about MatX are out there egging us on and adding in your 2 pennyworth, and hopefully bringing in lots of new people.
Yeah, absolutely.
So what we're going to do is close down the camera, but you know who we are now, and we're going to go through our presentation. So here we are with the first screen. We've talked through what we're using it for with the RCM and the RCOG, but I think a key point is no hierarchy, just people. And we're very proud of the way that women have come forward and joined us, not just as participants in MatX, but as leaders and equally staff. And I don't know if you want to say something, Florence, about the kind of staff that we're getting involved and who we'd like to reach out to.
So we've got all sorts of health professionals, so obviously midwives and obstetricians, but also paediatricians, anaesthetists, health visitors, GPs, midwifery support workers, students. We want to reach out to all different sorts of professionals that may have involvement in looking after women and their families in maternity care. And then also other people that support women. So we've got doulas involved, and we've got the NCT involved, obviously MSLCs, but anyone out there who's interested in supporting women with their maternity experience. Perfect. So this is a poster which explains what we are and how we've done things and what we've done so far and what we're doing in the future. And this is a poster that I've just been presenting at the Royal College of Obstetricians and Gynecologists World Congress this week. And it's also available on our MatX website. You don't need to worry about what's on this poster because we're going to use it for the structure of our talk. So it's just to give you an overview and know that you can come back to it, but we're now going to dive into it in a bit more detail. So to start off with, why did we get started? Well, I was part of the Strategic Clinical Network in London, and we'd had quite bad results in our CQC Women's Survey in 2013. So we had 6 of the 7 worst performing trusts in London, and we decided to form what we call patient experience group at that point in time. And I decided to lead that because I was very interested in how we improve women's experience. Off the back of that, obviously there have been national reports such as Francis, and then more recently and specifically in maternity, the Kirkup report, as to how we should really be involving all levels of staff, all sorts of disciplines of staff and women in developing care. That then obviously flowed through to the National Maternity Review published recently this year, which we were very delighted to be able to help with their engagement events by using the Who's Shoes game that we're going to talk to you about. So there's a lot of need for change. There's a lot more need for personalisation of the way we look after women and treating women as individuals. There's also a need to challenge assumptions. A lot of what we do is we do it this way because we've always done it that way, and services are organised around how we like them to be organised as an organisation rather than around women and their families. And we're going to come on to talk a little bit about the new work we're doing, but part of that work is looking at women that fall between the gaps in services. And we've put in arbitrary geographical or definitions that divide women up and affect their care. So this is about challenging those assumptions and working across boundaries. So we thought we'd start with a very small pilot, possibly 1 trust, and that actually became 5 trusts. But we're quite ambitious, and it kind of spread like wildfire. So you'll see in a bit from 5 pilots, so 1 in each sector of London, This has really taken off, not only in terms of the Who Shoes workshops spreading, but also in terms of the online community of women and professionals that have come together to work on maternity experience.
So it was a big vision, wasn't it?
It was a big vision, and Gill's taught me to kind of stick my neck out and poke people. So I tweeted this on New Year's Eve, you know, why not aim high with my 2015 ambition?
To improve maternity services, as it's turned out now, moving into global, and we'll come on to that a bit later in terms of some of the conversations that we're now having. So if I tell you, I'm Gill, and if I tell you a little bit about Who Shoes, it's a tool that looks at issues from different people's perspectives. So for me, it's really exciting to put together scenarios that are genuine statements, concerns, good practice from the people who are the originators of those kind of comments, and to put those into Who Shoes scenarios so that it feels as if somebody real is talking to you, and then to get the participants in the room to react to those issues, respond to them, talk about them, find that some of those things relate very closely to themselves and what their own issues are, and then the exciting part really is to co-produce really realistic, locally owned solutions that take people forward, and to bring together physically in the room people who, quite honestly, wouldn't normally talk together, and certainly wouldn't always talk together as equals, and to talk about things that really matter. So what is Who Shoes? It's in the form of a board game. You can see a group from one of our workshops here, and as we've said, it deliberately tries to bring forward the kind of people that Florence was talking about in a multidisciplinary way, but giving them an opportunity to really talk to and learn from and interact with users, people using their services, in a way that really doesn't happen very often, and hopefully to create a really relaxed environment so that it's easy to talk about no hierarchy, just people, but to make that happen in practice, you've actually got to create the right conditions. And we try and create a really relaxed atmosphere, and we use quite unusual tactics such as cake, and we'll come on to the use of cake a bit later on. So on the right there you've got this card, which has been, is that your favourite card, Flo, do you think?
Absolutely. I love this because it's just so obvious that things change over time. So this card tells me two things. One is a woman's birth experience will stay with her for the whole of her life. So this is Gill's mum, who's 94 now.
She is now, yes.
And she's still thinking about when she gave birth. But also the fact that things now we look back and think are completely ridiculous, that then were commonplace.
So if the technology works here, which we're very optimistic about, you're going to listen to my mum talking about this for a few seconds. And then if we can go into kind of interactive mode and get people perhaps thinking about what happens these days that might seem wrong or odd to future generations.
Changing times. When I gave birth, they forced me to take castor oil, which always made me sick. And it did. What current midwifery practices do you think will seem wrong or odd to future generations?
So when we had our workshop at Kingston, which is about 18 months ago now, everyone decided lithotomy would be the thing that would seem wrong or odd. And actually that was quite pertinent because it came up in the most recent CQC survey that women were giving birth in lithotomy even when they were having a spontaneous vaginal delivery. So there was absolutely no need. So I, off the back of that, in our workshop, did a lithotomy challenge for NHS Change Day, which you may not have seen on the internet. I've had a surprising number of people at the conference this week actually say, oh yeah, we've seen you in lithotomy. Is it something to do with that? So what thoughts do you have about what might seem wrong or out of date in the future? Very interesting. In fact, that cropped up in a question and answer session with the president of the Royal College on Sunday. And yes, there was general agreement in the room that this was a bad thing and that we should change it. But there didn't seem to be much sort of ownership or initiative to do so. And I did slightly challenge the room saying, You know, let's not wait for the college. It's up to each and every one of us in this room to start changing what we're saying and doing, as well as thinking of a more system-wide solution for that.
And I think this has been a powerful feature of the workshops. You literally see people with kind of light bulb moments where they think, I didn't realise the effect of the words that I'm using, you know, not through any malice or that these are good people, but just suddenly seeing that words that have perhaps been accepted medically and what they actually mean to the women who are receiving those words, and how easy it is to change, really.
Yes, I wondered about whether we talked about midwifery care and team care. Someone's talked about obstetric care to me yesterday, but I'm not sure about that, because it's really about having the multidisciplinary team, which might involve all sorts of other people. Yes, yeah, that's an interesting one. I think certainly in my unit that's very driven by the anaesthetist. We get ticked off if we haven't done it, but you're right, it's assuming everyone is going to end up in theatre.
I'm trying to remember extra things that the obstetricians said on Sunday. Am I right in thinking they said induction, somebody?
Yes, someone did say induction. Oh no, suggesting all induction would be outpatient. Yeah, and again, that's a very interesting question, because there's so much work on CCG interpretation, whether you computerize it or whether you add ST analysis or what you do, and actually none of it makes any difference whatsoever. So I think you may well be right. Yeah, failure is a huge thing, yes.
I did ask the chief exec of the NHS, Simon Stevens, how he would feel if he was told that he'd failed to dilate, and I think that comment has probably stuck with him more than if I'd said various other things. So sometimes we just need to perhaps be a bit bold and make people feel the impact of something rather than just talk about it at conferences.
Yeah, and that's interesting, because also in terms of guidance on how you should do intermittent auscultation and how you check someone is competent to do that is very hard to find, because I know the London Clinical Network have been looking at how do you ensure competence in intermittent auscultation, and it's a really tricky one.
So what we're going to do now is a program really of just a few slides, possibly set to music, and that's the reason for having this picture here. And the picture here just brings back nice memories, because we had a really wonderful workshop as one of our pilots at Queen's Hospital in Romford. But as we walked into the hospital, there was a piano playing, and it just gives a community feel, and I think it kind of supports what MatExp is trying to do to make a holistic approach rather than purely medicalised.
So obviously that looks fun. We get people to have a really nice afternoon having a workshop, but it doesn't stop there. What's really important is encouraging people to take action. So hopefully you saw in that slideshow that people were sitting around playing a game, and then it's being drawn up into a lovely graphic by a graphic facilitator. So people are jotting their ideas on post-it notes. Those are going over to the graphic facilitator, and she's drawing stuff and feeding back. So at the end of a workshop, we ask people to pledge what are they going to go away and do differently. And this might be something that an individual pledges, in terms of, you know, some of the language we've talked about, not using that, or trying to promote skin to skin in theatre. So it might be something, or introducing yourself properly, hello, my name is. So it might be something simple and individual, or it might be something for a whole unit. So, for example, at Kingston, we spent a lot of time redesigning our maternity notes in conjunction with our women, and that's obviously something that might take longer to do. It's a much bigger project involving more people, so that might be a unit pledge. So here are some examples. So Kingston held the very first pilot 18 months ago, and these are just a few of the examples of things that people pledged and that were completed. There are an awful lot more pledges than this that have been completed, but I've just had to pick some to give you a bit of a feel for what might happen. So we have a maternity graffiti board, which you can see in the bottom right corner, which is simply a chalkboard in the entrance to our maternity unit, and there's also one on the postnatal ward. And people can write up in real time what's their feedback, how do they feel about the service they've received. Sometimes people write up stuff we need to improve on, like they waited too long. Sometimes people use it to write a birth announcement. Sometimes the kids get involved and start drawing stuff saying welcome to their baby brother or sister. It's a really fun, really nice interactive way of seeing what's going on. And as a member of staff, it's absolutely lovely walking in and out of work, looking there to see what's popped up new on it. And every now and then we rub it all off and start again. So a space for people to leave new comments. I've had some joint sessions between midwives and local doulas to try and promote understanding. You know, midwives are very kind of worried about doulas getting in the way and interfering with how they communicate with women. Doulas really want to try and support women. They've been asked to support the women. And so we've done some joint work looking at better understanding how we work together and sort of building that relationship so there's not so much distrust when someone comes in with a doula. I mentioned the notes co-design. Our notes have got a lovely page now where a woman can put her photograph, she can write down what's really important to her, what are the things that she's concerned about or the things that she wants people to know. We've got a new users page on our website, and we've got more dads antenatal classes. So that's just a little taste of some of the actions that came out of a workshop. NHS change date, so I already mentioned from that lovely castor oil card, lithotomy cropped up, and I thought I would do a lithotomy challenge. And after a little bit of poking on Twitter, the first person to try it out was actually Professor Jim Thornton, you can see at the top there, in Nottingham, who was kind of challenged by some of the Matex mums on Twitter and went and did the lithotomy challenge and said he really wouldn't recommend it. It was very uncomfortable. I'm in the middle there, and if it wasn't bad enough being a lithotomy for an hour with the door open and people wandering in and out, I've got a film crew and Helen Bevan and people talking across me. And at the bottom we have Matthew Hopkins, Chief Exec of Barking, Havering and Redbridge. And the point of this is it's not a gimmick, it's to get people thinking and get people talking. So I think we ended up with about 17 different people in about 10 or 11 different organisations across the country having a go at the lithotomy challenge. And I also know that the page on the website, My Lithotomy Challenge In, has had a lot of hits from people in America. So it gets people thinking, it gets people talking, and really it's something that is very relevant today because, as I said, quite a large number of women are delivering in lithotomy who really don't need to. And when we do need to use lithotomy, perhaps for an instrumental delivery or suturing, actually we could limit the time that we keep a woman in that position. We could think much more about the dignity that we give her, how to cover her up, how to come and talk to her face first before we end up going down the bottom end to do things. And it just really focuses your attention on how to improve things. With the Strategic Clinical Network, we produced a range of best practice tools, and these are on the London Strategic Clinical Network website. They're free to use. So we've got a workshop toolkit that tells you how to run a workshop, gives you some templates of who to invite, slides you might use to lead the workshop, seating plan and things like that. We've got the In Their Shoes video, which is a film, an empathy film, which we used the themes from the workshops to create a film, which is a training film for staff. Again, it's on the SDN website, it's on YouTube. You can easily watch it, it's 5 minutes long, and it does come with some questions, a training kit that you can use. But you can just simply watch it at your shift handover and discuss it amongst yourselves about what you think about it and what makes you think and feel you might do differently. And then on the left, we've got some best practice case studies, again, on the Strategic Clinical Network website, of 10 ideas. So one of them was the graffiti board, one was an airline-style introductory card for a postnatal ward at Guy's and St Thomas's. So ideas that you could copy across. So even if you're not having a workshop, you could easily lift off and copy some of the ideas that came out from the pilots. What we didn't really anticipate when we started the pilots was the level of interest there would be in maternity experience on a much broader basis into what we were doing. And it's been an incredible privilege, actually, to have so many healthcare professionals and, most importantly, users. So whether you want to call them mum leaders or patient leaders, I don't know what the right word is. I would say friends, or, you know, we're a Matex gang. There's an enormous number of people out there doing unbelievable things. So it's really helped sort of give people an opportunity who perhaps had ideas and were doing things, or felt like they needed permission to do something, to just go off and do stuff. So we've had Flaming June this time last year. We did an alphabet, did oxytocin October, we did Matex Bon Tour with a little camper van, and Jill and I were a little bit over ambitious and did Matex Advent stories with a Stella story a day in December, which I have to say we bit off slightly more than we could chew, but it's an incredible resource if you want to dip into it, on Stella stories of some of the highlights of what we've achieved over the year. So there's an enormous amount of activity outside the workshops in which anyone can get involved. So the workshop started in London, and really fantastically, we had 235 people to our pilots, and 93% said that the workshop changed how they think about maternity services, which is absolutely outstanding. The first workshop outside London was in fact Guernsey, who jumped in last June. Jill, I don't know if you want to say anything about Guernsey in particular.
Just that it stands out, and it was obviously exciting to take it beyond the pilots, but to start with really quite a challenging workshop. And obviously that was the first one at the time outside London, but as I've gone on, I've found that each one is inevitably different groups of staff, different issues, different demographics. So Guernsey, a tiny island, they had been not very long before a failing service and were already well on the way to turning things around. And we kind of bit the bullet and really got everybody in the room together. And I think Anna, the graphic facilitator, and I both said afterwards that we felt we probably made the most progress in that particular workshop in terms of fear or issues that were very real, and the sort of magic of people coming together who, as I said at the beginning, perhaps wouldn't normally talk together, and really just relaxing, and they got some lovely cakes and some very real discussions, and really making progress together. And then that progress goes on, and this is the key thing, after the workshop, and builds the relationships and hopefully gets embedded as a kind of improvement approach and a collaboration.
So then in London, there are different ways of approaching this, and South East London decided to commission it as a whole sector approach, so that all the trusts there got together, and in fact this was led by the MSLCs, so the Maternity Services Liaison Committees, and they literally went round each trust in turn, with people from one trust coming to the workshop, the previous trust. so that they were passing the baton round. So we were really delighted. So King's, Guy's, Thomas's, the Prue and Greenwich had some fantastic workshops. And then since then it's kind of exploded. So we've got in London, we've got out of London. So Gill did a workshop in Colchester last week, and we've got one at the Homerton next week. There's kind of workshops popping up all over the place. We had a very successful one in UCLH in April. So it's really spreading not only within London now, but up and down the country, which is fantastic to see, because you know for each workshop that's held, you've got 40 or 50 people who are being infused and galvanised into action and going off and telling their friends and hopefully encouraging and galvanising them.
And I think from my point of view, in terms of Who's Shoes and the whole of my kind of social media approach really, is I'm absolutely delighted to be able to connect different hospitals. So we've got two main models for maternity. One is a just do it option, and one is more of a sort of let's talk you through it right from the beginning to the end and co-facilitate the workshop with people. And we've had a really good number of each. And from my point of view, I'm very happy to come and work with you and to run a workshop with you, never for you. But if you can link up with another hospital who perhaps have already done something. So, for example, there's a lead at the moment, somebody who has really had nothing to do with Matex Who's Shoes so far, but is an ex-colleague of somebody who ran very successfully one of the London workshops, then we talk that through together and basically make sure that you're set up to succeed, in which case Just Do It has been a very key part of the whole approach in Matex and very much applies to the workshops as well, but with that kind of quality control caveat.
So what we're trying to explain, I guess, is it's set off a kind of whole range of actions all over the place. And I tried to think about how to represent this. So part of this is user-led. So we've got a lot of things where people were either working on stuff and Matex has amplified and given them more opportunity to get the word out, or new things initiated. And then on the other side, we've also got professionals who are already doing things that, again, we've been able to link in with, or new things that have started. So, picking out, for example, the GP Infant Feeding Network literally started, I think it's about 2 months ago now, from one tweet from a GP of, do you know how I might source some stuff about breastfeeding? And we were immediately able to connect her, and she's set up a group. She's got a whole load of GPs interested in supporting breastfeeding women. She's holding tweet chats. She's just gone from 0 to 60. And that's just one example of the very, very many little sort of almost feeling random things that are happening as a result of Matex. So really anyone can go off and do anything, respecting people's views and working together to improve experience. And the really gratifying thing is Matex, Gill registered it before the first workshop with Simpler, and I really didn't understand what that was, and kind of went, oh, okay then, whatever. And it's been a phenomenal success, so that lots of people are using it, but it's also being adopted by some of the kind of key people that we'd want to influence, like the National Maternity Review, the CQC, and NHS England. So it's really excellent. And in fact, I had a meeting with some people at the Royal College of Obstetricians and Gynecologists yesterday, and the woman I was meeting went, oh, Matex, yeah, I'm seeing that everywhere. I didn't know what that was. I didn't realise that was you. So, we're really getting people's attention by all using the same hashtag, even if we're all working on a huge variety of different things to improve maternity experience. So I'm going to come on now a little bit to our new project. So we were very fortunate, a challenge fund was put out in March to bid for, although there was a rather short time frame. And we bid for some money to extend some of our work into 3 specific areas.
Nobody's Patient was inspired partly by my experience with my son Hugo. I had HELLP syndrome at 24 weeks. I was in a hospital 2 hours away from home, and was lost really in between maternity, neonatal and intensive care. I was in intensive care myself. And so it's really about getting these different departments to talk to each other, because even though they're on separate floors in the same hospital, they might as well be on different planets. Everyone's working towards their own services. So it's about making sure those women don't fall between the cracks and their families get the care that they need and deserve. It's really challenging and stressful and emotional time anyway. So it's about making sure there's no additional upsets to make things even worse. So we're really pleased to get this funding. We're getting more scenarios from staff and from mums and from other family members as well. And we're looking forward to the workshops.
A couple of other important things. So we've got babies that end up in paediatrics. So Helen, who's been very involved in MatX, she found herself on a paediatric ward with very minimal support from maternity services, despite the fact obviously she had a newborn baby. So we're also looking at babies on paediatrics. And then we've also been working hugely with Catherine from the Pinks and Blues, who's highlighting the issues about women who lose their babies in the second trimester of pregnancy and very much fall between gynecology services and maternity services, with very arbitrary rules about where you should or shouldn't be cared for, and all sorts of very difficult issues in terms of what gets counted, how that baby's birth gets recognised, does it get recognised as a baby, do you get maternity leave, and all sorts of really, really difficult issues for these women who have been through a very tragic experience. So I'd just like to say that the title, Nobody's Patient, was a real kind of light bulb moment. As I was writing the bid, I saw a lovely tweet from Carolina, I think her name is, and she said, I felt like nobody's patient, and it just suddenly the penny dropped that that's what these women are. And as we've been doing the project, a lot of people have come forward and said, yes, that's exactly how they felt. They felt like there was no one person taking ownership of them. They were nobody's patient. They're being passed from pillar to post or between different staff groups. And that's what I meant at the beginning about things being organised around organisational structure. So you've got maternity services and paediatric or neonatal services in separate departments, in separate bits of the hospital, rather than thinking they need to come together around that woman and her newborn baby and that family. This is a conversation I've got involved with recently. So Andrew Weeks, who's an obstetrician in the MatX Facebook group, has been having some conversations back and forth with people about guidelines and the fact that women are feeling that guidelines are treated as rules or sort of tram lines, and that they're having difficulty when they go to an obstetrician or a midwife and ask for something that they feel is important to them, being told, no, you're not allowed to do that. Most units will have their own version of a national guideline, but then sometimes people interpret that incorrectly. So, for example, at my trust, we offer induction of labour to women who are over 40 at 40 weeks, because we know there's an increased risk of stillbirth, twofold increased risk. But we also know that that only is 4 per 1,000 versus 2 per 1,000. So if I was seeing a woman in clinic, I would discuss those, how her pregnancy is to now, how does she feel about induction versus not induction, these are the risks, what would she like to do. But I know some other members of the team are, well, you're over 40, you will have to be induced at 40 weeks. Those are the rules. And if not, they'll then get into a conversation with a woman about, well, if you don't do that and you don't follow our advice, your baby might die. And that isn't really helpful to anyone. So, I mean, that's an exaggerated example. I'd love to say it didn't happen like that, but I know full well it does. And I've had a really interesting conversation with the Royal College just yesterday to look at whether we could design some sort of advice that would make people feel more confident about this. So I brought this up at the Labour Ward Leeds meeting, and some obstetricians felt very confident and comfortable with going outside guidelines and giving women a personalised risk and personalising their care. And some obstetricians were quite wary, concerned about medico-legal issues and how things would be viewed if they were not following the national guidance. So I think there's work to do here, but it's good news because there seemed to be a body of people that are interested in working on it. And like I said, I've linked up with the college and the Women's Voices Network at the college, and they're having a meeting in July to see what we might do to try and improve this for people, because I don't know, it seems to be a barrier. People using guidelines as possibly they're scared, possibly it's an excuse, and it is about having an informed conversation. So it isn't about saying, yes, of course, go off and do whatever, even if we think the evidence is there that it's quite dangerous. But it's about having a conversation where then that woman can, with the right information, make what she feels is the right choice for her, because risk is, it's her risk, and it's relative to her what she feels is going to worry her or what she feels confident with. Yeah, actually that cropped up that NICE are now starting, rather than having a professional version and a lay version, they're now apparently trying to write everything so that everybody could read all of it. And I think that's a really interesting idea. Why on earth have we got into a position where we've got professional guidelines and lay guidelines? Because it really needs to be open and accessible to everybody. And I do understand you have to use some medical language, but you could easily explain what that is. I quite often give people references to national guidelines regardless, because I want them to go off and read the information.
So we were delighted that the need for a grassroots campaign was recognised in the National Maternity Review report. The wording is slightly odd in my view, in that it talks about we need it to happen, and arguably with 424, I think it is today, 424 million Twitter impressions, there is a very effective and inclusive grassroots movement happening through MatExp. So the way that we're engaging people, it's been really great to see people from all different walks of life coming on board with MatExp. It was very interesting for me personally to be at the Labour Ward Leeds meeting on Sunday, because obviously normally I wouldn't be at something like that, and to have the chance to, Flo and I did the same presentation there, and to try and influence obstetricians to get more involved, because obviously all the viewpoints, it's only when we actually get everybody talking to each other, and social media can be a tricky forum for any of us, but to kind of coax people really to kind of get involved and put their heads above the parapet sometimes, and for other people to appreciate why that might be difficult, genuinely very difficult. So the social media side has been really interesting, and we're really using all sorts of different media. So the kind of underlying approach is just do it, and it's been fantastic to have different people with different interests taking the lead on setting up a website, building on existing and setting up new Facebook groups. I've got my own Pinterest page, but it's collaborative, and if anybody here wants to be allowed to, or dear, I've used the allow word, wants to be able to post directly onto Pinterest, then just get in touch, and I can put your email address up there, and you can post direct. All of the things we're doing are trying to just bring people in and not exclude anybody. Stella stories have come along a bit later in the day, but are an incredible way of reaching people, and with a good story we can reach 30,000 people in about 2 days, and that goes way beyond the power of blogs and most of the more conventional methods that we've been using. So it's not about choosing any one, it's about using all sorts of different media and films. We've got quite a few things on YouTube as well at the moment, and the more the merrier. So obviously with social media you're reaching out to people internationally. I was delighted that our friend Ants from Switzerland this morning was tweeting, and we've had some fantastic conversations with people all around the world, and there's some very active interest at the moment in taking Whose Shoes to Uganda, which I'm really excited about. So I did get invited to present as part of the introductory session of Helen Bevan's 24-hour Transformathon, and to talk about MatExp as a change platform. and to have someone like Helen recognise it as a change platform when Florence and I weren't really quite sure what a change platform were, but we're learning, has been really, really exciting. And we're grateful to people like Helen who've given us, new opportunities through NHS Change Day in particular. And we know that it's been reciprocal and that MatExp has really helped the kind of whole boost for NHS Change Day as well. So we've got fun and lemons, which we really haven't got time to explain to you now, but there was a 10-minute film which I made for that Transformathon in the unlikely event that the technology failed. For a couple of minutes to show a bit of a speeded up film of an actual Who's Shoes workshop in action.
Anyone can do anything, so the more the merrier. We'd love people to get involved. We have this fabulous website which Lee just did off her own bat. We have a Facebook group that Emma, Helen and Suzanne created. We have Twitter that Jill and I are a bit excessively tweeting, and really there's all sorts of things people can get involved in, or you could start something new. So I think it's about trying to make people feel, even if you don't have a workshop, that if you see things in your daily work that you think you could go and change, that you could do better, then what's stopping you? Go do it and try and bring along a few of your friends as well.